All right, good blaster at your side, innovations in refractive surgery. And we talked about how our practice, we focus on surgical care, and most specifically on refractive cataract surgery as well as refractive surgery. And then I also do cornea, but the topics of cornea were not part of today's meeting. Maybe next time. All right, and this is our practice. And again, Dr. Maloney, congratulations on the announcement you made. You brought tears to us. But we're excited to continue to work with you and take advantage of your knowledge and expertise. All right, so refractive surgical treatment, there's a menu of options at every stage and at every age. And one thing that we pride ourselves at Maloney-Shamie-Hura Vision Institute is that we don't push the limits of safety of one option because that's all we have to offer to our patients. We know with everything in medicine, you really need to have the breadth of the options for your patients so that if a patient is on the cusp of one option versus the other, you have to weigh the risk-benefit ratio. As you can see on the left side, there's refractive error that goes from +6 all the way to -15. On the bottom is the patient age, and then you see LASIK, PRK, SMILE, the corneal-based refractive surgical procedures really kind of are great fit for that myope in the pre-presbyopic or peri-presbyopic age, up to about -6 to -8. Beyond that, we'll talk about EVO ICL as a better option because of the vision quality. And then refractive lens exchange kind of fits in that as a hyperopic treatment option or for the older presbyopic patient, and then ultimately cataract surgery. And you see an area at the bottom left that's empty. And that's where presbyopia drops potentially can be helpful because those are the younger or nothing, no surgery whatsoever. So the young early presbyopes who are hyperopes, presbyopia drops are great. The younger hyperopic patients, we really have to weigh the risk-benefit ratio. There's often not great surgical options for them. Those are patients we work closely with you to really come up with the best solution for them. Let's first focus on the hyperopic patient who's in the older age, kind of peri-presbyopia age, and refractive lens exchange.
Yeah, we've joked about this multiple times today, but symptomatic presbyopia is really coming into the forefront. It used to be something where it was kind of a self-isolating phase of life before the advent of social media, and now everyone's posting on social media about the need for reading glasses to see their computer at work, to pay a bill and write the check. And we saw this during the pandemic become more and more prevalent as people were looking at themselves on camera all the time. And all of a sudden, if they're presbyopic and not using some form of correction for that reading power, they had to wear reading glasses, they had to do monovision. And so we saw patients coming in and seeking surgery. And the amount of uncorrected presbyopia on patients who report difficulty across the country is massive. And there have been a lot of studies reporting a negative impact on quality of life. And so this is something we see all the time, and historically there have been maybe a limited amount of options available. But like with most things, improvements in technology, improvement in modern surgical techniques, we now have options we can offer patients for this.
And these patients are seeking solutions, and they're looking online for solutions. They are empowering themselves with the knowledge. They come to you for those solutions, and if they're not offered an option, they seek elsewhere. And it's really important to deliver on the options that are safe and effective for them. Sometimes no surgery or no option is available. That's really good. But we're here to talk to you about those cases that can benefit from a surgical option. These are patients who have tried other modalities and they're really seeking a more permanent option. What we call refractive lens exchange is a wonderful option for those hyperopes who are presbyopic. Some people we're now thinking about calling it refractive lifestyle enhancement, potentially. And it really is. It's a lifestyle enhancement for many of these patients, especially those who we talked about the emmetropes or the post-LASIK patients who have enjoyed excellent vision and now they've become presbyopic or more hyperopic and they're now developing difficulty. These are patients who have multiple glasses. They're not able to tolerate monovision. They're not able to tolerate the presbyopia correcting glasses and so are seeking a more permanent option. They're usually highly functioning. They're executives. This is a 53-year-old second opinion for LASIK. I would say about 10% of our patients coming in for LASIK consultation kind of fall into this category. They're frustrated with their vision. They need multiple glasses. They have glasses for computer, for their reading, for driving, and year after year their prescription keeps changing and they're just simply not happy with their their vision. As you can see, this person is a hyperope, is correcting to 20/20, and they're saying, well, why can't I have the surgery that my mom had to correct their vision? And their workup, usually with these patients, we try to do a monovision trial in the office to really see if they can tolerate it. And if they can tolerate monovision, we ask, have you tried it with either drops or contact lenses with your doctor? And if they have tried it invariably, or if they can tolerate monovision, we then have to think about alternate options. In this case, the patient couldn't tolerate monovision in the clinic, felt dizzy or nauseous, and when we corrected the right eye for reading and left eye for distance, but when we reversed it, and actually in this case, the dominant eye was the left eye when we tested dominance, but when we were trying monovision, they tolerated the reverse. So keep that in mind. Just because they show you the dominance of one eye doesn't necessarily mean they're going to prefer that eye as their distant eye. And in this case, again, seemed okay, a little strain, and so they weren't really fully committed, and so we recommend contact lens trial with monovision, and we often work with you to really fine-tune that before we make a surgical commitment. And the treatment options for a patient, if they want full independence from glasses, if their contact lens trial is successful for monovision, we can offer them LAL Plus with monovision target, or a non-adjustable lens with monovision target, although that's not as ideal, because as you know, with monovision, it's really important to land that distance perfectly on distance, and that near and that sweet spot. The light adjustable lens with the extended focus allows for kind of more of a it's more forgiving as far as where you land. If it's not successful, the options are do nothing, or refractive lens exchange with a trifocal lens, or refractive lens exchange with a mini monovision, or EDOF. But ideally, these patients, again, if they tolerate it, do LAL Plus with monovision. If they don't tolerate it and they're really motivated with the PanOptix Pro, we're very comfortable proceeding with the quality of vision that they can get with the PanOptix Pro.
Yeah, that's a really good point. So, and I want to just take a second and pause on this, because if a patient enjoys monovision, we know they're going to love it with surgery, right? We are able to trial that beforehand. But otherwise, really, the options are do nothing or maybe some form of mini monovision. But other than that, with refractive lens exchange, it's usually utilizing diffractive optics. And historically, it's really hard to satisfy a patient who is best corrected to 20/15 before surgery and use a multifocal or trifocal lens in their eye and give them that same quality of distance vision. Because as you saw, just inherent to how diffractive optics works, there's just a little reduction in contrast sensitivity. Each generation of lens, that gets better and better, but we can't cheat the laws of physics. We can't cheat the laws of optics. So we may take someone who doesn't have the ability to see up close or even at intermediate, we may functionally get them completely out of glasses at those ranges, but we know that if patients don't like the quality of their distance vision, they tend to be a little unsatisfied after surgery. And that's where I think Dr. Shamie and I are maybe a little different from other surgeons. We're a little bit more conservative in that regard, because taking someone who's 53 years old, doing refractive lens exchange on them with a multifocal lens, getting them out of reading glasses and maybe for computer, if they don't like their quality of distance, psychologically, that's how they're going to perceive that change in the vision for the rest of their life. They're always going to think their vision was better beforehand in glasses or contact lenses. So there's a lot of nuance here, and we really do a deep dive when we're in clinic trying to figure out how often are they using those glasses and contacts before surgery? What are they walking around? If someone's walking around uncorrected with that refractive error and they're 20/25, 20/30, that's a different story. But if they're used to that 20/15 vision, historically we've been very hesitant to offer them multifocality until now we're thinking with PanOptix Pro and some of these other lenses that are demonstrating higher light utilization, offering better contrast sensitivity, less dysphotopsias. I think, again, as technology improves, so can maybe our offering to patients. And so let's dive in looking at the same graph. Let's talk a little bit now about laser vision correction in the form of LASIK, PRK, and SMILE.
All right, so going back to the graph again, we're talking about myopic patients now. So we've shifted gears, and we're talking about the different options for our myopes. At MSHVI, we use LASIK using the iDesign 2.0 Refractive Studio. And what this is basically with refractive surgery, it's really important, much the same way as cataract, but maybe even more so with refractive surgery. It's very important the diagnostics done ahead of time, because data in is outcome out. And the better your data, the more data points you have, the more advanced your technology is in capturing the true refractive error of the eye, the better you can then optimize the patient's refractive outcome. And in these patients, again, their correction with your contact lenses and glasses, they're seeing 20/20, 20/15. So you have to meet them at least at that point, if not better. You have to make sure that you match their vision post-op as good as they have it with contacts, and ideally, in our approach with the iDesign and with really optimized wavefront guided technology and Topo-integrated technology, we often can get them actually better than 20/20 vision. So the maps that this device basically maps the entire optical pathway inside the eye with wavefront analysis, and also maps the entire surface of the cornea with corneal topography, which is really first in class, only FDA-approved treatment that also can use the same type of elevated diagnostics to treat presbyopia with monovision. It's the only system with customized vision to use iris registration to compensate for torsional changes in the supine position. As you know, when patients lay back, their refractive error may shift because their torsional orientation, and if the pattern of treatment doesn't match that torsional change, then you could potentially not optimize their refractive correction. And it is the most tissue-saving laser for us corneal specialists. It's really important when we do refractive surgery, for all of us, when we do refractive surgery, to truly save the tissue to minimize the risk of ectasia. So LASIK with the iDesign Refractive Suite, MSHVI, this is actually data that we've collected, monocular uncorrected visual acuity at 6 months post-op. Our data and FDA data. Our data actually was better than the FDA data, which is often not the case, but it is when we are kind of obsessive compulsive. We found that greater than 97% of patients had 20/20 or better vision, and actually 77% of patients had 20/16 or better, and we had about 10-11% of our patients who post-op had 20/12 or better. And this is incredible for post-LASIK patients to have better vision post-op than they did with correction pre-op, and large percentage.
And that 77 jumps to 93% for 20/16 vision or better when we're looking at binocular uncorrected visual acuity at 6 months. And I just want to recognize Dr. Maloney, because it's really because of his efforts and meticulous detail to analyzing our postoperative outcomes that we've been able to refine our refractive nomograms and be able to get patients these sort of outcomes. Last week we had our ASCRS meeting here in Los Angeles, and we had some visitors from Singapore come over, and they had visited our practice back in 2007, and they are still using Dr. Maloney's nomogram from back then, because even back then Dr. Maloney was very meticulous about crunching the numbers, looking at the data to make adjustments to get patients this sort of outcome. And so 93% of patients 6 months out with greater than or equal to 20/16 vision is incredible, but we have that kind of personality where we always want to know what's coming down the road and how can we do better.
So you want to lay the groundwork?
Yeah. So much like, if those of you, show of hands, who was here joining us at last year's symposium? Okay, about 2/3 of the crowd. You heard us talk a little bit about Smile Pro, and we talked about how we hadn't adopted Smile Pro yet, but we were looking at Smile Pro. We look at everything. We look at all future technology, but ultimately, like we said before, it all comes back to patient outcomes. So we're always looking at what is potentially going to give patients better vision. A year later, Smile Pro still, unfortunately, doesn't have things like iris registration, pupil tracking, cyclotorsion control, things that we've had with LASIK for a very long time. And so while we continue to look at it, it's not something we've yet adopted because we don't feel like it's going to quite yet give the same level of excellent outcomes we get with LASIK. Well, there's a new sort of technology that is in development. It has not quite yet really been commercialized or become mainstream, known as ray tracing. And this is a concept where the technology is able to develop almost a 3D AI-assisted optical model of the eye and utilize not just topography, not just wavefront optimized or wavefront guided, not just tomography or epithelial mapping, but to take all of these measurements and reconstruct the eye and the level of refractive error, as well as higher order aberrations, and account for that. And so some of the early results from India are suggesting maybe a slight reduction in higher order aberrations, maybe an improvement in contrast sensitivity, and as Dr. Shamie will talk about here shortly, an improvement even from those outcomes we're getting today.
Yeah, and I think ray tracing for refractive surgery is really exciting because, again, we talked about data in is out comes out, and the more data that this gives us, and it will truly create a three-dimensional replication of the optical system of the patient for a truly customized treatment profile that is unmatched. And the data has been really impressive, the outcomes that we see, and we're really excited to be first in line in offering this to patients. And it does address the shortcomings of ablation profiles using current technology. Now,
so essentially, it's just using that technology again to generate the most customized treatment for patients that we've had before. And so it also is going to offer a level of predictability for how patients potentially will heal. And that's something that historically we've utilized when refining or adjusting our nomograms, but there's some thought that there may be less of that analysis needed in the future as AI, out of all things, comes forward into the forefront of refractive surgery.
And AI, again, you were mentioning last week, we had our meeting here in downtown at the convention center. AI is front and center in ophthalmology and surgical care. Again, in a way, optimizing the way in the way that we create nomograms that are customized and personalized, not just to the patient, but also to the surgeon and to the environment in which the surgery is done. And much of this had been done previously, but not in the way that AI can do it efficiently and truly optimized as best as it can be. So ray tracing based LASIK, more eyes are seeing 2016 and 2012 or better with improved nighttime visual quality. One of the things that we are concerned about with LASIK, especially in the higher corrections, is the effect that it can have in the quality of nighttime vision, which is why in our practice we really shy away from offering LASIK in those with myopic refractive error of more than -8, because the nighttime quality of vision is simply not as good with LASIK as it would be with an implantable contact lens, for example. And -6 and up to -8, in that kind of gray zone, it all depends on other parameters. But with ray tracing, it's possible that we can consider, again, expanding the profile of refractive error correction with LASIK, expecting better outcomes because of the ray traced pattern of treatment.
So if we take a perfect segue, if we take a 25-year-old patient with stable level of myopia, they're seeking independence from glasses and contacts, we see this level of refractive error, -9 sphere, minus diopter of astigmatism in both eyes. This is the situation where we tell patients just because we can doesn't mean we should. Could technically this patient be treated with LASIK? Yes, those are pretty thin corneas for that degree of high myopia, but technically it could be done, but the patient's going to be at high risk of ectasia, higher risk of nighttime dysphotopsia, as they already have mild dry eye. This is someone we are definitely going to be recommending EVO ICL for. Versus, let's say, someone with no dry eyes, thick cornea, moderate compound myopic astigmatism, totally normal corneal imaging, tomography, topography, that's someone who would do great with laser vision correction.
They would do great with LASIK, SMILE, or even PRK, depending on what their preference is. But more and more, we're actually seeing patients very much like this, who fit that profile of a LASIK patient, who come and request the EVO ICL because of its reversibility or simply because it sits better with them as far as the idea of having a surgery that is additive rather than ablative. So here's a case, 25-year-old nurse, developed GPC with contact lenses, hoping to gain independence from contacts and glasses. Because of her vocation, she just doesn't want to have to wear contacts anymore and glasses get in the way. Reports no family history of eye problems except need for glasses. And on manifest refraction, she's right at that cusp of, do we think about EVO versus LASIK in this patient? In fact, she has reasonable corneal thickness. Her corneal topography, though, on first look, looks essentially normal. There is a little bit of reverse kind of form frust, where there's greater steepening superiorly, which sometimes can be an atypical presentation of form frust, although highly unlikely, but nevertheless something that gave us pause. And I just wanted to present this case only to show that sometimes on first look, a patient can seem like a great candidate for LASIK, but it takes us doing a little more digging to really get a sense, is this truly a patient who's a great candidate?
Yeah, and this is where advanced diagnostics can really come into play. So a patient like that, certainly contact lens use, chronic contact lens use can lead to that. Form fruus keratoconus is very rare. Maybe 1 to 2% of all cases have that sort of superior steepening as opposed to inferior steepening. But we're fortunate in our clinic we have the latest advanced diagnostics. And so we're looking at just the front four-map refractive map here of the same patient. And again, you can see just looking from a color standpoint, there's some superior steepening here. Probably a little bit too small to see the values, but if you look at the pachymetry, you'll essentially see that there is thicker cornea up top compared to below. And that's sort of the main sort of finding here.
And then on the posterior floats, there's essentially normal. I mean, there's really nothing that really stands out significantly. But when we dive deeper, you can talk about this, and then I'll talk about the patient again.
Yeah, and again, just to make it relevant to everyone, how many people in this room have some form of tomography? Pentacam, Galilei? See a couple hands going up. Okay, yeah. So it's important to differentiate true posterior elevation, which can be sometimes the earliest sign of form fruus keratoconus, much like epithelial mapping can sometimes be accurate at predicting or picking up on subclinical keratoconus. But there's a difference between that image on the left and then, Dr. Shamie, if you go back one slide, right there. So we're seeing the numerical values go up here. We're seeing a little bit of yellow, orange, maybe borderline red. This is not necessarily a patient who has true posterior elevation, because sometimes patients who have a significant amount of anterior corneal astigmatism, this is just simply what their corneas look like when you're looking from the inside out and you're seeing that corneal cylinder. So it's important, even though we get a lot of data, to understand how to interpret the data. So if we go to the next slide, the color scale is real simple here. So if there's anywhere from 18 to 20 microns of posterior elevation, and it's central, and especially if it's disconnected from the periphery, that's probably suspicious for a patient who has form fruus keratoconus. Assuming they weren't blinking during the scan, everything was aligned, it's a good measurement, no lid interference. But also, like we talked about, if there's a significant difference, more than 30 microns or so between the top of the corneal pachymetry and the bottom, that can also kind of turn on sort of
red
flags. And then finally, the actual red flag is the Bellin-Ambrosio Enhanced Ectasia Display, which you're looking at on the back of the four-map refractive. You'll see this final D value, and it's summarizing pretty much all of these metrics and combining it into one easy-to-interpret score. And if you see that yellow or red, and there's other things kind of that you're wondering, are these real or not, that's a sign that this patient is probably not a good candidate for laser vision correction.
But like anything else with advanced technology, it's important to correlate that with each other. So when we have multiple modalities that we assess the eye. If, for example, the area that's thinner doesn't necessarily match with the area of steepening, you then wonder about other conditions that could cause it. Could it be warpage with the contact lens and such? But when multiple parameters point at the same concern, then it's much more validating as far as the red flag and gives us pause. But I think it's also important to know when to pivot. So we pivot away from corneal-based laser vision correction when there's clear indication for form fruus keratoconus, obviously this bottom one, pellucid changes or posterior elevation. But the other things that can help us, and you can kind of, this history of this patient.
Yeah, if the patient has been wearing glasses for 1 or 2 years, we have the previous prescriptions, and we compare it to today's refraction, we're noticing a myopic shift. We're noticing a significant increase in the astigmatism, especially in that left eye. These are all concerning signs, in addition to all those anterior segment imaging signs we were a little concerned about.
I love getting history from the patient when they're seeking refractive surgery to know, obviously, for stability, but also for things like this where it points at potential risk for form fruus or ectasia. And so even though the corneal thickness is right, the refractive error is within range of LASIK, in this patient, we talked about pros and cons of laser vision correction that's corneal-based that could potentially put them at risk of ectasia versus a safer option for them, like the toric EVO ICL, to avoid risk of ectasia in a patient that has a borderline shift in refractive error, that there's maybe some questionable findings on their pentacam and some history of eye rubbing, and this patient has done really well. And I can sleep at night knowing that this patient will not be put at risk. And this is what's, I think, really important, because a surgeon who doesn't do EVO could convince themselves that this patient will be just fine, and what's the big deal? I mean, I can see them back if they develop ectasia, we can do collagen cross-linking, but prevention is absolutely critical in refractive surgery, because refractive surgery, of course, is an elective procedure, and EVO has given us an opportunity to save a lot of patients from outcomes that they would have been at risk for. So the EVO ICL is a newer version of the ICL that we have been implanting for 20 years, 20 plus years, and the EVO is the evolution of the same technology. It's not new. Patients ask, is this a new option? It is new, but it's not necessarily, it's a modification of a previous platform that we've used for many, many years. As long as LASIK has been around, ICL has been around. The difference is that there's a central port that allows for aqueous circulation around the ICL, and this then allows for hydration of the lens, and it allows for healthier environment of the lens, such that the concerns about cataract is minimized, and we'll talk about risk. Also, it prevents the need for laser peripheral iridotomy. These patients are in their 20s and 30s. They have healthy eyes, and I felt uneasy about performing peripheral iridotomies in these patients to ready them for the ICL, because obviously it's a damaging procedure if it's not necessary. The EVO has allowed us to avoid that. The indication for it is adults 21 to 45 was the FDA study, but we've implanted it as old as 55 in patients who have no cataractous changes in their eyes, and they do well with monovision. It is for myopia of -3 spherical equivalent or more, with or without astigmatism of up to 4 diopters. 20 years experience again with eyes globally. So again, it's not experimental, it's not new in the sense that we've had a lot of experience with it, and over 3 million EVO ICLs have been implanted worldwide, and it does come in toric.
And we can go on and kind of cover this. Let's skip this for the sake of time. Yeah.
All right, so safety. Implantable contact lenses is the thought is it's more invasive or more risky than LASIK. A lot of patients come in, they have many friends who've had LASIK, so they're comfortable with the idea of LASIK. And then they are not necessarily a great candidate for LASIK for many reasons we talked about. And when we present them the idea of EVO ICL, they feel that it's more invasive. One, because it's new to them, they've never heard about it, or two, because it is an implantable contact lens in the eye. So we add the contact lens behind the pupil. But the reality is, when you look at the studies looking at the safety of this, especially the EVO ICL, out of 4,000 plus cases that were implanted up to 5 years, this is not a short-term study, this is looking at these eyes up to 5 years, there was not a single case of cataract. So the risk of cataract that we often quote to patients, it's non-existent in this study, and unless it was a traumatic surgery, the risk of cataract is minimized because of that central port. And pupillary block, there was one case out of 4,000 plus cases that developed pupillary block, and that's because the surgeon got a little lazy and didn't remove the viscoelastic around it. Pigmentary dispersion, no cases suffered from that. So truly a safe procedure, and this is the clinical study that was done that led to its FDA approval, but you can also comment on.
Yeah, these studies have been replicated across the world in various countries. As is quite common in the United States, sometimes we're the last to get technology. So even though the EVO ICL has been FDA approved since April of 2022 here, there's 13 years of experience worldwide, and over 3 million of these ICLs have been put in. And you can see the safety profile is just incredible.
All right. So a challenge is ICL sizing. So we've shifted from the typical approach to sizing for ICL, where it leads to a forgiving vault. You know, as we know, the ICL needs to be sized appropriately for the eye so that it doesn't touch the natural lens, or it's not too vaulted that causes potentially angle closure. And we have moved to AI-calculated controlled vault. We traveled to Zaldivar Eye Institute, and Dr. Hura, do you want to share your
Yeah, so ICLs give us fantastic outcomes. We do these surgeries every week. I'm thinking about doing ICL surgery on my sister. I'm thinking about doing ICL surgery on my fiance. But again, we just don't like resting on our laurels. And even if we're getting good outcomes, we want to see, can things get better? And so last November, Neda and I flew 18 hours all the way down from Los Angeles to Mendoza, Argentina, to join our good friends at the Zaldivar Eye Institute, who have been implanting ICLs for over 3 decades. And we spent a few days with them, and we even saw them do cataract surgery on some patients in their late 60s and early 70s who had those first ICLs put in 30 plus years ago. And they removed those ICLs and examined them underneath the microscope. They sent them off to the microbiology lab, and it was incredible to see no scarring, no fibrosis, no pigmentation. They joked that they could take those ICLs, sterilize them, and probably reuse them. They're not doing that. But they joke that's just how biocompatible that polymer material is. But they've really developed something special, which we'll get into here. And you can see this test patient, Dr. Shamie herself on the right. That's Roger Zaldivar, a very good friend of ours. And he's doing ultrasound on Dr. Shamie's eye. And they've developed AI-driven software that has led to a very accurate form of predictability for vault sizing.
And the Zaldivars are truly leaders in ICL surgery. Zaldivar Sr. was one of the first to implant these lenses, and we were really privileged to be invited to go and learn firsthand and bring their technology to the U.S. And to our practice and to your patients. What they have developed, this AI-driven, AI-powered sizing is called ICL Guru. It's using Sonomed UBM and basically inputting the UBM images into their system and using AI and thousands of cases that they had done to essentially tell us the most optimized sizing for each eye, truly customized to the eye.
So start and stop, boom, right there. In just that short amount of time, that just took 50 frames of a patient's eye and done in succession 3 or 4 times utilizing AI. It's looking at the best quality images and looking at the entire anterior segment. And so it's looking at different parameters, not just white to white, but internal dimensions as well. And so much of this has become automated. We've really been very pleased with this in our clinic. Shout out again to our amazing clinical staff. They are now able to get these images from patients in sometimes under 2 minutes. And so versus old UBM technology where we would bring patients back for a second visit, it was kind of maybe a little uncomfortable. Yeah. Now we can do everything in a very streamlined process, and it's AI that's powering everything.
And the AI-powered best frame processing is done, which then, again, gives us the ultimate vault that we can expect based on the lens that it tells, the lens size that it tells us to put in. And this is really critical information and critical step in optimizing outcomes of EVO ICL patients so that the concern about sizing is not there and there's no concern about lens exchange.
And so this is what the output looks like. This is a variety of patients, but you can see green is great, blue is, okay, maybe a little too great, and then purple is definitely too big. And so we're looking at multiple parameters here, mostly the predicted central vault, but also the predicted peripheral vault, as well as the angle. And this is something that is very interesting because most people, they just think about, well, what's that vault when I'm looking right at the ICL, right at the slit lamp? Anyone who's having more than 10 diopters of myopia treated, there's actually 2 different base curves to the ICL. And so the central vault is not necessarily the peripheral vault. And so if someone has a very shallow central vault and they had a tremendous amount of myopia that was treated, they may have an even shallower vault still. And so the beautiful thing about this software is it tells us the prediction for both of those, as well as telling us what are the odds of a patient going into potential angle closure. And we can utilize these measurements then, as well as all of our other advanced diagnostics, to really confidently pick out the right size ICL for a patient.
So our take-home message is truly to offer a safe and effective care. The surgical toolbox needs to be complete. That is, you saw that graph we presented at the beginning. It's really important when your patient seeks refractive surgery that the surgeon that you refer them to is someone who has expertise across the spectrum of options and doesn't feel uncomfortable shifting or pivoting from one option to the next simply because this option is what they're most comfortable with. And we are really privileged in our practice. Again, the legacy that Dr. Maloney has laid down and what we're carrying through is that we have expertise across the different options, and we feel very confident when we offer a surgical option to a patient that it is the safest, the best option. Sometimes no surgery is the option we offer. Determining patient candidacy and non-candidacy is key, and technology matters. And I hope that in the last half hour, we were able to share some of the things that excite us about what we do and the tools that we use to deliver on the promise that we make to you and to your patients. And with that, we're going to end the session. Thank you so much. Thank you for your attention. I want to thank PER. Dr. Maloney, come on up here. I want to thank PER. They took this meeting on, the responsibility for this meeting on about 3 years ago, and they have taken this meeting to the next level. We so appreciate your dedication, your commitment. It has been a really wonderful journey, and I look forward to further growth. Please give us feedback on the surveys that come your way, and if you have any questions about CE, receiving your CE, don't hesitate to ask. And I hope that you'll reach out to us. We're available to you anytime, and we look forward to inviting you back to other symposia, both next year, this one, and then other smaller gatherings that we have.
So the CE code, if you can't read it in the back, for COPE 4636, for CME 2646.
All right.
And then usually at the end of these things we say goodbye, but we don't mean it like I'm about to say it.
Aww.
Goodbye.
Thank you. All right. Well, we're happy to stick around if you have any questions, and thank you again for spending your Sunday with us.